Hey, look, everybody's here. Great. Hey, Steve, we're just about to do the introduction. Hang on one second. All right. I'm going to just share this out with people.
There we go.
Silence my phone. Turn this phone off.
All right, guys, we are live right now. I'm going to share this with people, and then we are going to get started. Hello, and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host today, Raj Gupta. I'm coming to you from Nashville, Tennessee, and I have a really phenomenal panel today to talk about a fun topic that I think all of us are going to enjoy. For those of you guys who are watching live, I want you to put comments or questions into the comment stream. We'll see them up here. We'll talk about them. I'll pose them out to our guests. And make sure you share out. If you're watching already, share out with your friends so they can join in on the conversation as well. Now, before we get started on the topic, I do want to mention one thing, which is that we have a meeting coming up. We're going to talk about a couple of meetings coming up really soon. The first one I want to talk about is the ASRA spring meeting. Now, this is going to be a combination in-person and virtual meeting, so you can join however you want to. It's in Orlando, Florida, May 13th through the 15th. It's coming up really soon. So go ahead and go to the website, asra.com, and register for the meeting. I've already seen the program. It's phenomenal. If you're attending in person, it's going to be a great meeting to start up the post-pandemic conference world, and I think you're really going to enjoy that. If you're only able to join virtually, you're still going to get some amazing speakers, amazing talks, and I think it'll be worth your effort. So go to asra.com and register for that meeting. Second thing is actually something I'm doing later tonight. Tonight, I am part of an ASRA Hot Topics conversation. This is we're focusing on what fellows and trainees should do to promote their career after they finish training. How do you get started? How do you get your feet on solid ground right after you finish your training? So if you're a trainee, if you know some of your trainees that might be interested in this, you can still register. This is a virtual Hot Topics conversation that we're doing tonight, 7 p.m. Eastern time. So just go to asra.com, click on that link, and register for that session. Again, we want it to be interactive, questions and answers. So register to join live, and then you can talk to all the speakers and ask your questions. Now, I'm going to throw it to one of our guests here, and I'm going to bring all our guests up here and look at this wonderful panel. Man, we have so many good people to talk with us today about this topic. But before we get started on introductions, Amit, do you want to do a quick little plug for the RA UK conference coming up as well?
Raj, thank you very much. Yes, please. So coming up this May, the 5th and 6th of May, so not very long to go, we've got our RA UK meeting. It's going to be a virtual meeting with a difference. So it's going to be a little bit different from a standard Zoom meeting. Going to be some interactive sessions, a chance to ask the speakers questions, some live scanning, and some really fun and dynamic symposia. In fact, Johnny Wilkinson and Stephen Haskins are both going to be featuring in that meeting. Nadia, we're going to get you next year for sure. Please go online, www.ra-ukmeetings.com, and register for that. Thank you, Raj.
Okay, while you're talking, Amit, why don't you do a quick introduction? I mean, I'm sure everybody listening knows who you are already, but tell them one or two sentences about who you are, where you work, and some of your interests there.
Okay, so my name is Amit Pawa. I'm a consultant anaesthetist at Guy's and St Thomas's Hospital right over here in London, and I'm the current president of RA UK, Regional Anaesthesia UK. I am a massive ultrasound-guided regional anaesthesia enthusiast, and I am very privileged to be in the presence of such great experts in point-of-care ultrasound, which hopefully is my next stop destination.
Excellent. Johnny, you want to unmute yourself? While we're across the pond in the UK, why don't you do your introduction real quick?
So hi, and thanks so much for the invite to do this. And again, great faces on here, except mine clearly in my lockdown haircut here. So I'm Johnny Wilkinson, and I'm a mega POCUS enthusiast. Started off my career in regional anaesthesia, funnily enough, and then it was a natural transgression to go across and do further things, and hence POCUS. So it's a great foundation to start off in, and I think a basis in regional anaesthesia gets you flying within POCUS. So yeah, and I'm also a big fan of use of social media and medicine and everything else, and run a website, and that's about it for me. So I feel privileged to be here, and thanks for inviting me.
Great. Now we're going to slowly move west. We're going to go to New York City. Steve, you want to do your brief introduction? Again, you probably don't need much of an introduction for this crowd, but go ahead.
Oh, yeah. Thanks again for having me, Raj. So Stephen Haskins, I'm an anesthesiologist at the Hospital for Special Surgery, which is an orthopedic hospital in New York City. Regional anesthesia and acute pain trained, did my fellowship at HSS where I work. And from there, kind of got interested in focused cardiac ultrasound, which then turned into a passion for point-of-care ultrasound in general. And so I'm adding new skills every year as I have opportunities to. And I was very fortunate to help with the founding alongside with Nadia of the point-of-care ultrasound special interest group for ASRA back in 2017, the creation of our introduction to perioperative point-of-care ultrasound course, which we will actually be doing in Chicago in November. So we'll be on the lookout for that. And also helped lead the charge alongside Nadia and Johnny on our recent recommendations for education training for point-of-care ultrasound that was published just a few weeks ago in Rapham. So been busy in the last few years.
Yeah, you've been.
Thanks again for having me.
You guys have been doing phenomenal work. So, and off to Texas, we're going to talk to Nadia here. Nadia Hernandez. Hey, you want to do your introduction?
Hi, I'm Nadia Hernandez. I'm an anesthesiologist who's trained in regional and acute pain in New York City at the Mount Sinai Hospital by Meg Rosenblatt and Christina Jeng. I came over to Texas probably 6 years ago and sort of revamped the regional anesthesia and pain fellowship here. We had Stephen come over and set up our POCUS education for our residents and our faculty over here. So we have sort of been pioneering the South with POCUS education. Mm-hmm. I would like to say that my left hand is really just always has an ultrasound in it. And it's true. I learn new things every day. Yeah. So I'm excited to hear, what's going on across the pond as well.
Excellent. So just as a quick note here, we have a comment, hello from Bangladesh. I think this is our first time having somebody comment, Dr. Saeed Islam, saying hi to us and watching us from Bangladesh. So good to have such an international crowd listening to us today. So let me introduce this topic this way. So all of us are sort of tech junkies. That's kind of how we, it's one of our hobbies and interests. And I always enjoy at the meetings going through the exhibit halls and kind of seeing what's the latest tech happening with ultrasound, because, it's such a big part of regional anesthesia and now point of care ultrasound that, we need to understand the equipment, the technology, and then we of course want it to grow and get better. And for those who aren't old enough to remember, the first little laptop style ultrasounds, from GE and Sonosite were some of the big players early on that revolutionized regional anesthesia. And so my question for this conversation today is, what happened to some of the cool stuff that we were promised that I never really saw come to fruition? And then what's really happening with ultrasound that's actually going to make it interesting and useful and also, of course, fun and cool going into the future? And I think that we're at this sort of inflection point where things are changing and it's going to change our practice. And Nadia, I'm going to start with you real quickly because you said something that was really important, which was, I always have an ultrasound in my hand. Well, why is that even possible?
Well, handheld ultrasounds are a thing now, and they've become, with new technology, they've become very affordable. So although our hospital is purchasing one for every operating room, I bought one for myself that I just sort of keep in my purse, in my back pocket. I work in a trauma hospital, and our patients are very, very sick. I mean, they come in a helicopter, and if they're really dying, they bypass the ER, they come straight to us. So oftentimes someone's working on an A-line, and we also have to get in a really big introducer at the same time, and there's one ultrasound in the room, and it's very easy. The other day I sent Stephen a 4-second video of a tamponade, because it takes a couple of seconds to make a diagnosis now, and it has just changed the way that I practice anesthesia. So I have a hard time putting it down. I mean, why do things blind when you can see? And that's just my opinion on it.
Yeah, Amit, you were one of the reasons I sparked this podcast is you've been commenting a little bit on some of this stuff, and I apologize at the beginning. We didn't go through disclosures. We should go through any conflicts of disclosures. I don't have any conflicts related to ultrasound technology, but as you guys are speaking, if you guys have a conflict that the audience should know before we talk, we're trying to limit how much we're talking about brands. I really want to talk about where the technology is moving, but we just for complete disclosure, everybody can mention it as they're talking. So Amit, you can kick off the next part here and do whatever disclosure you want to say. But tell me a little bit about how you're looking at handheld ultrasound and what you're seeing.
So in terms of disclosure, I received some honoraria from GE and for teaching, and I was fortunate enough to be given their latest product to use, but without any financial component related to it. And with regarding Butterfly, I first saw the Butterfly actually thanks to Dr. Haskins at one of the ASRA conferences. So one of the break times he showed it to me, and thanks to Johnny, he hooked me up. So I purchased my first Butterfly IQ. And subsequently, I'm a product tester with them, so I was given the IQ Plus. And so, how was my involvement? Got involved with it? Well, first of all, I found the technology fascinating. I couldn't believe that you could hold something in your hand and all the machinery would be in your hand, and you could connect it up to a phone or an iPad or whatever it was, and actually have ultrasound with you. And I started my training in ultrasound in regional anesthesia before ultrasounds were commonly available. So we had one machine per theatre suite. If you wanted to do a regional anesthesia procedure, then you'd have to kind of wait in line or queue, or if the ultrasound wasn't available, you'd have to carry on without it. And that's for vascular access or for any regional anesthesia. So what I was really excited about was to see what the technology could achieve. And I just like the fact of always being able to have something with me. Despite the fact I work in a large central London teaching hospital, we don't have one ultrasound per operating theatre. And that's the dream, right? So if you don't have that, the fact that you can have something in your pocket and use it the whole time, that's what I was excited about. And my main interest was because I haven't quite jumped in with both feet into the world of POCUS yet, I wanted to know how effective these handheld machines were at being able to replace or to substitute in for the slightly more advanced laptop-based machines. So that's where my interest lay. Started off with one device, which is the wired device, the Butterfly, and I've now had a look at the wireless devices. So I'd be interested to hear what my other colleagues think about that. But that's where I'm at, really, seeing how I can use ultrasound wherever and whenever I want it. And we, I've had a debate with Johnny in the past about whether we should use ultrasound for arterial access all the time. And I have to confess that now I only ever sight arterial lines with ultrasound. I don't bother. Even there are some purists that say, "Why do you need to do it? It takes 2 seconds if you do it by palpation." I've got to admit, I've got some days where maybe I'm not as hot as I should be. With ultrasound, that element is removed. So it's handy access in my pocket the whole time.
Yeah, I remember that same conversation about central lines and people going, well, you should have enough expertise to do it most of the time and use the ultrasound for the challenging ones. But now, at least in the States, it's pretty much an expectation that you put in a central line with ultrasound visualization. Johnny, Amit kind of reached out to you about that. I'll tag on one comment he made there, and I don't know if you've had the experience yet. So we went from big cart-sized machines to laptops to plug into your tablet, and now wireless. I don't know if that's the next big wave. Are we going to get completely untethered? And I don't even need a big purse to carry around to carry my probe. I just can throw it in my shirt pocket pretty soon, along with my phone on my hip. And is that going to be enough?
Well, I just similar to Amit, conflicts for me. I do quite a lot of work with GE. I've received honoraria from them, and the same as Amit, product tested for Butterfly and received an IQ Plus probe from them. So that's that out of the way. With reference to your question, can I come on to the wireless bit, actually? Because for me, we've obviously reviewed lots of different devices on the website. And for me, the wireless devices just haven't quite hit the mark yet. They're just not quite fast enough. The refresh rates aren't quite quick enough. So I've always been a little bit disappointed by the wireless devices. And same as Amit, I've got in my possession in this office, there are about 6 different devices in here, one of which is GE's latest, guys. And we're going to be telling you a bit more about that at some point. And as Steve and I have released information on, for me, the foundation and training starts with an ultrasound device you can put your hands on, get access to, as Nadia said, the handhelds, and I think they are an absolute gold mine starting point for everybody, including the regional anesthesia, vascular access, and everything else. But wireless it's just not quite there yet. And I don't think, well, got to be careful what we say here. I don't think anyone's yet designed a probe like the Butterfly one, which can do everything it can in a wireless form. And I'm sure it's coming, but it's going to be a big device, and I think that's the problem. So for me, it's wired and handheld and linked into your phone or your tablet. And for me, carrying around the ability to put the 5th pillar of clinical examination into any patient you approach, whether it's down in resus, on the ICU ward round, is key. It's the key to everything now for me.
So Steve, Johnny indicated what the use case is for it. I want to go back a little bit. We're still using, for the most part, 2-dimensional ultrasound. And I know we're going to hint at something that one of the technologies does, where it does 2-axis ultrasound, which I think is really fascinating. But let's rewind a bit. So I was promised 3D ultrasound. I was promised enhanced needle localization for doing procedures. I was promised, super high resolution. What happened to all that stuff? I mean, did we trade off smaller, lighter for some of those advanced technologies?
So I don't have any disclosures, just to put that out there. I think that's a great question. The reality is, I think it depends on what you think, where you're approaching it, because I think there has been a lot of interest in 3-dimensional or 4-dimensional, depending on sort of the company and how they sort of frame it, in cardiac imaging, transesophageal and transthoracic, because it's very helpful for them to visualize valves. That way, when they're doing repairs intraoperatively, or assess patients postoperatively or preoperatively. So I think there has been a clear clinical demand for that type of imaging that meets sort of the functionality of having an enormous machine that can do all that processing, because it's sort of a stationary machine in your cardiac ORs or perhaps in a preoperative testing type of setting. I do think it requires a great deal of processing power, which is probably the limitation. And as we do find that there's more interest in having mobile machines, be it a laptop or a handheld, because the versatility is really important, and being able to have access in all parts of the hospital, or be able to very quickly pick up a machine and bring it into an operating room for a block or a vascular access procedure, or to assess a patient. Probably the clinical demand for that has outweighed the interest in putting that extra processing power into creating that 3-dimensional or 4-dimensional image. So I think a lot of those higher end, higher processing, sort of futuristic AI related topics that I think we saw as the future of ultrasound when we were thinking of it largely as a stationary device that could do more things, where it is in the OR. I think we've realized that there's more demand in it being available around the hospital than necessarily the processing power. I will add on to what Johnny said earlier, when it comes to education and training and learning. the best device is the one you have access to, right?
Right.
So if all you have is a handheld because that's the one that you're able to purchase yourself and your institution isn't willing to buy one, or ultimately that's what you're going to fiddle around with in the operating room during your free time to work on scanning, then that's great. Ultimately, the higher end machines with the better resolution are ideal for learning because you have a bigger screen and you're gonna catch the more nuanced elements of any sort of particularly diagnostic exam. But yeah, I think access has been more important than some of these more advanced imaging modalities that were promised.
Yeah, in the early days of these smartphones and stuff like that, I remember there was as many of you guys might know, photography is one of my hobbies, and there was a photographer, professional photographer. His catchphrase was, "The best camera is the one that you have with you." And when the smartphone camera era came up, and we've obviously seen it in real time now, that more pictures are taken with your phones than any other big camera or anything like that. So this is probably the equivalent transition for ultrasound, is that the best ultrasound is the one that you've got in your hand, in Nadia's left hand, that's ready to go and use. At least she can, as long as she's there, she can point it in the right direction. So Nadia, one of the cool things I saw recently, Steve mentioned AI, was one of the manufacturers kind of floats labels onto your screen in real time, using artificial intelligence to detect the anatomy and then actually kind of basically overlay labels. And right now they were pretty simplistic text labels. I think that they were showing a cardiac ultrasound and estimating ejection fraction. And obviously that's in very early stages, but you could imagine a future where basically there's a little arrow that says go here, or this is what you're looking at, or there's something bad right there. Do you think that's dumbing down the process too much, or that's where we need to be looking in the future to kind of expand the reach of this tool?
I think that there's value in extra information, and I always feel this way, as long as we don't depend on the extra information. So as long as you still know the cynoanatomy yourself, and you are able to identify these structures, you can agree with what the machine is telling you. Same thing goes for EKGs. The EKG will give you a reading, but I'm not going to depend on the machine to tell me what the EKG says. However, if I take a quick look at it and I disagree with what the EKG machine says, I might have a second thought about it. So I think in that sense, it would be helpful to have an extra opinion about the cynoanatomy. And if I disagree with what is being told to me by a machine, then I can use my own personal knowledge to decide if that's where I'm going to inject, or in fact, that is not what I'm going to do. So,
I'm going to throw a couple of questions at you here that came in the comment stream. So first question from Dr. Rahim is, do you think the big ultrasound machines are history in the very near future?
No, not yet. I think that the smaller machines are good, and in fact they're very good, but not quite there yet. And also, there are many indications where you do on a larger machine. So certainly, the larger screen size is useful for teaching. If you've got a couple of people around you, you're trying to crouch over a small screen or an iPad or an iPhone or whatever tablet or smartphone you're using, I don't think that's useful. But also, I do think, as I think Stephen alluded to earlier on, you need to have access to machines which have higher processing power to look at the more advanced scans. You can't see everything you need with the small machines. For now, if that's all you have access to, I think is great. But I don't think we're quite there yet with the small machines. Certainly, if you're in an institution where that's all you have access to, you can achieve a lot with that. But certainly, the more that you start to scan, the more you start to see, the more you start to learn, you do benefit from having the slightly more advanced machines and some of the more advanced technologies, which we can touch on later. So I don't think we're quite there yet. Not yet.
So second question from Dr. Rahim is there any machine available that permits use of 2 or more probes at the same time, like a dual scan? And that's sort of a teaser to one of the things that we talked about earlier. I'm not sure why you would need 2 probes on somebody at the same time.
Does that mean, is the question, scanning two parts of the same person at the same time, or is it to generate two views? I'm not quite sure. Or is he? I don't know.
So I'm gonna interpret for the sake of our conversation. So let's say two views at the same time, and sort of. I know you've been practicing with one of those technologies, not with two probes, but with two views at the same time.
Absolutely. I think a few of us have had a play with that technology, and there is the technology available now that gives you dual plane visibility at the same time, which has a number of uses. I don't want to steal Nadia's thunder. I'm sure Nadia wants to talk a little bit about that, but that technology, that technology is there, and quite what role it has in all aspects of ultrasound care is yet to be determined. But certainly one of the main advantages I see to that is vascular access.
Mm-hmm.
We had a debate on Twitter recently about different ways of sighting art lines, and I generated, without meaning to, I generated a little bit of a debate amongst some of the UK colleagues about, whether you should do it out of plane or in plane, and a lot of people felt very heated about this. But interestingly, I was teaching somebody only recently, in fact yesterday I was teaching a junior trainee a different technique for how to place an internal jugular vein cannula, and I took the advice of Robbie Erskine, one of our colleagues from Twitter, about how we took a short axis view of the internal jugular vein, got the individual to place the needle on the fattest part or the widest part of the artery, and then at that point rotated the probes so we were in line. And this is the first time that I taught it that way, the first time the trainee had seen it, and her mind was blown. She's like, wow, I can actually see exactly what I'm doing, and I'm not guessing. You can appreciate when you tense against the wall of the vessel exactly how much pressure it takes to go through it. And there is technology that allows you to see both of those things at the same time. That is cool. I think that's very cool.
And Johnny, I'll throw this question to you. How someone specifically, Dr. Islam from Bangladesh asks, how good is the butterfly probe resolution practically? He says he uses a portable Chinese ultrasound machine, but he's eager to get something better in an affordable price. And he's in a government district hospital, so they don't have any of those yet.
Yeah, I think certainly one area that Butterfly came in at was the low to middle income countries and giving them access to this technology. And the device itself, you can't argue with the price of it. Subscription on an annual basis, that's fine. But I think they've come in with a real niche product. And I think are we allowed to mention that this biplane technology is theirs at the moment? I think that's what Amit was itching to. He was just scratching his leg, thinking, "Do I say it?"
Yeah.
So I think they have been a pioneering company, and this is not because I get paid by them. I'm saying this. I just think that they listen to what you say. Then a couple of weeks later, they seem to come up with something that's workable. Now, the thing for me about all of this technology is. It's only as good as the user at the end of the day. And as Nadia pertained to, you've got all this AI technology. And this is where it's a bit like ICU ventilators. One does pressure controlled ventilation. The other one calls it wibbly wobbly mode ventilation. But they're all the same thing. They're just rebranded.
We don't have that in the States, Johnny, the wibbly wobbly mode.
You don't have wibbly wobbly. Oh, well, this is what I've been using for COVID.
I'm still learning the difference in the language in the UK. But everybody learns something every day.
There you go, the wibbly wobbly mode. So, but they are going to sell their products with more interesting AI. But again, with great power comes great responsibility, great Amit power, in fact. So you've got to be very careful not to be sucked in by some of these things that actually may not be that useful. And there is another company, and I'm not going to say who because it's fairly obvious, who have produced the most fantastic lung sweep technology that literally looks like you've slapped an enormous 4-foot probe onto a chest. So they're all coming up with these things. As to how useful they are, very debatable. But I think we've all got to be careful to understand that the foundations come in teaching, the foundations come in good education, mentorship, and being able to get people through and to a degree ignore the AI until they really need it and experience enough to use it. So there you go.
Yeah, so part of the reason I mentioned some of the old stuff that kind of fell by the wayside is because that was what everybody was enamored with at the time. Like, that's going to revolutionize things. So I always like to couch our expectations about the current technology, the newest buzzword, the newest cool thing that we get caught up in, and then realized that maybe there isn't really a practical use for some of those things. So I wanted to get some of you guys' experiences about that. And what I'd like to round robin one more time about is kind of, what do you see coming next? Or or almost a wishful list, like what needs to happen with ultrasound to make it even more valuable, even more useful? Where are the friction points right now with it that would make expanding its use both in the number of people that can use it, but also the breadth of use cases? And I'm going to start with Steve on this one, because Steve, you've been part of this POCUS revolution that has expanded people who had an ultrasound for one purpose and have found this whole another use environment. So what is it that's missing? What's missing from the technology that you have access to right now that you wish to see in the near future?
Well, in terms of barriers to universal access, it's interesting. I did one of the last ASRA meetings, a pro-con debate. It's a time to get rid of the stethoscope with Karen Boretsky, who's a POCUS enthusiast, and she was on the con side of the debate. And
that was there. That was a good pro-con. I remember listening to that one.
Yeah, you don't want to get into a street fight with her, but. So I mean, she brought up what I think is the most fundamental barrier to access, which is the finances of an ultrasound machine. We talk about, it's gotten affordable to the point that individuals can purchase their own probes and machines. Yes, but not any individual. You have to, if you are in a country where, drop in, the type of money you need to buy an Apple laptop computer, is pretty expensive to put that much money towards an ultrasound device, and you really have to be committed to that cost, because it can be a big hit. And all the stethoscope, which was that was the pro-con debate, stethoscopes you can buy for a few dollars, and so they will always be sort of more ubiquitous just because of that cost point. And I think we need to keep pushing for the price of these machines to get to a reasonable point where any sort of trainee would feel like, oh yeah, that I can buy one of those and start using it, and kind of show it off to a faculty member that may not be as enamored with ultrasound, but now it's in their face and it's part of the conversation. Now we have to have departments say, all right, we're gonna throw a bunch of money at this, and we consider an investment in the future, which involves convincing them that this is important. So I think we still have a ways to go. We've come leaps and bounds in just the last decade. I would say 10 to 15 years in terms of the cost point, and part of that is innovation and part of that is competition. And so we're certainly moving in the right direction from that perspective. And I hopefully we can get to a point where it's closer to buying a few textbooks, than buying a really sort of high-end laptop or a tablet.
Yeah, when I started, I mean, obviously those big cart-sized ultrasound machines were 150, 200,000 US dollars, and then we bought the first laptop-style ones, and they were $40,000, $50,000 with a couple of probes, and now we're talking about ultrasound devices in the $2,000 to $3,000 range US right now, and so there's been, and that's over the course of 15 years, a pretty dramatic. Hopefully that trajectory is still continuing on, and getting to a point. At some point, I think there will be a sort of asymptote that doesn't get any cheaper, because then it's not cost effective to even make the device. But hopefully we're still heading down. Nadia, what do you think? What's missing? You use it all the time, right? What do you want different in your device?
Well, I always say, people ask me all the time, if you needed a one ultrasound, what would you buy? And it's difficult, because if I have, and this is Texas, so if there's a 160 kilo patient, which we see often.
I'm in Tennessee, don't worry.
I'm not going to reach for a handheld ultrasound.
Yeah.
I want something where I can, switch to a probe and get the best image at 8 centimeters, hope my needle reaches. And however, that ultrasound is not as portable. And, our block team is mobile. we do all the blocks in the hospital. So we do wheel around ultrasounds. We also have handhelds. The handhelds, I wish that the image was as good as the larger machines. And I wish the larger machines were more portable. So I think in the future, they're both working towards that. And I know that in the future that there will be a machine that has the portability and has the image quality to where you can say, hey, this is the ultrasound that you need. But we're far from that. But I think that both are working towards that. Oh, and also I have disclosures. Right. So
forgot about that earlier. Sorry.
Yeah, I did some educational content for Butterfly that I also did some product testing. I have the Butterfly IQ Plus. Okay. And I do educational workshops for Sonosite, which I take honoraria for.
Okay. Johnny, I remember a few years ago, one of my little dreams that I kind of did a little poster on this because I kludged together some technology that I found from other purposes. One of my dreams was to have a headset where I could create a floating ultrasound image in front of me while I'm doing a procedure. So I don't have to look at a separate screen while I'm doing a procedure. I can look at my hands and the screen at the same time and sort of live in this augmented reality world of ultrasound. And it looked super cool, you know, with the glasses and it looked super cool. It was when I tried it, when my resident tried it, we were all getting nauseated and getting sick to our stomach and squinting. It was terrible. But you know, what's in the future? Do you see a future where we could see virtual reality, augmented reality helping us with this technology? We talked about AI. What's on the horizon as far as cool new stuff with this?
Well, I've got to say, I've always wanted to rock into an operating theatre looking like RoboCop, but that's just a dream that's never going to happen for me.
Before you get to that, I'm gonna tell you one thing. So where this came from is at my hospital when I first joined. This is 15 years ago. We had little Microsoft Windows tablet computers. There were Sony Vaio computers that were about this big that you could put on a little hip pouch. Had a VGA out, and we had a heads-up display thing on our head that would stand like this, and all of our operating rooms, this is not ultrasound, all of our operating rooms had cameras in them. And so you could have 4 cameras from your 4 operating rooms that you were supervising in a display in your eyepiece like this while you're walking around. 15 years ago, we had this. And it worked. It actually worked. It was just a mirror of the image on your computer screen. Patients hated it. They couldn't stand us wearing it. They couldn't make eye contact. And so that was the biggest problem, is that the patients were really uncomfortable with it. So yeah, it looked pretty darn cool in my opinion, but I don't think it was appreciated by others. Sorry, I interrupted your flow there, Johnny. Go ahead.
No, don't worry. It was prostatic. The flow was a bit prostatic, to be honest. The whole thing about, I mean, you've just described the Elon Musk approach to ultrasound there, haven't you? This is how he would do it. And actually, it is interesting. The technology was there even 10, 15 years ago. But I think just rewinding back to what you mentioned about the VR side, I think some of the future comes in haptic technology, actually. So, for example, we're getting involved with the development of a haptic technology whereby you can take an ultrasound user, they'll have the probe in their hand. So you've got Nadia and she's got the probe in the left hand. It's placed on an abdomen and she's scanning the right upper quadrant, but just can't quite find Morrison's pouch there. So what you do is you give haptic signal towards her, which will cause her to tilt the probe and move the probe, fan it or pan it in the correct direction because you've got your hand on her hand and her probe at the same time. Now we are actually in the process of getting this developed or discussions with a company that can do it, apparently. So for me, it's training, and the future is technology for training. And I'll go back again, AI is great, but you've got to be careful. And that worries me somewhat. And I think the other branch of the future comes in how we mentor our guys, and certainly Butterfly have a platform which is very good for telemedicine. So we could be at home, we can be viewing somebody's scans as they're doing it or afterwards to sign them off, for example. And again, I think this is where the future is. Yeah, we can have funky gadgets and reach inside a plaque's view of a heart and fiddle with the valves and so forth, but is that really going to help us? Because that's not what ultrasound is. Actually, it started off as a 2D modality, and now we're wandering into this tactile world? Is it over the top? I don't know. For me, some of it maybe is. So there you go. That's my garbled approach.
Dr. Shankar was saying that there's flexible transducer patent already. He's thinking that he can imagine a glove that's just a transducer. Although I don't know if the patient would be uncomfortable, you just gently rubbing their abdomen or their chest like that with a hand. I'm not sure if that would work.
There. Let's just get your heart a bit better there. The military certainly have probes that fit into a glove tip, fingertip.
Really?
As you may know about. So they already have this technology. And if you can imagine a probe the size of a finger, excusing the phrase, but you could literally stick it down around where the apex beat is. And some of these probes are a bit too big to get in those rib windows, as we know. But perhaps the technology is in minimization of size and so forth as well.
It's feeling very ET soon with the finger, but
home.
Yeah, Amit, what do you think? I mean, you're always playing with the latest cutting edge stuff, but what's next? I mean, they're obviously finding things that are useful, but there's obviously deficiencies in everything that you're seeing as well. Where's the next big leap?
So I think I'm going to be slightly controversial and say that I do think there is a role for some of the AI stuff, because one of the problems we see is that there's still a big appetite for regional anesthesia, and we still have a problem with not all patients having access to it because of the fear of technology, or people missed out that bit in their training. So they'll attend a course, they'll get a little bit of hands-on learning, and then they'll go back to their base hospital, and then maybe a couple of weeks or even months before they get their hands on a probe. So I think there is a role for, you get some initial didactic training, then for there to be a situation where you place a probe on the correct part of the body, and then the probe will identify certain tissue structures and highlight them for them. And that technology is there and is currently being developed. So I think there is a role for that. But as has been said already by Nadia and by Johnny, you kind of need to be able to interpret that as well, to not be solely reliant upon that. But access, I think, is important, and certainly picking a few basic core blocks that lots of people will benefit from, and having that technology to reinforce those structures as part of learning is key. The other thing is regarding needle tip technology. I think at the moment, a lot of the needle guidance software, I find if I'm ever using it with a trainee, distorts the image significantly, so the quality of the image is downgraded. I don't have so much of a worry about in-plane needling, but I think out-of-plane needling, to be able to identify the needle tip reliably, that would be cool. Some of the technology that exists at the moment, you have to use a specific needle with a specific probe and a specific manufacturer, and that's a shame. So I think something in the future that allows you to be able to identify the needle tip reliably would be useful. So AI for needle tip identification, and a little bit of AI for reinforcing what you suspect those structures are. That would be cool. I can also see there being a situation where you look in a certain direction with these goggles, and the image is projected like an overlay of where you are. If that technology existed, that would be cool. I think much of the excitement has been discussed already.
Yeah, I mean, you can imagine a situation. So, like, I use my phone. My phone has LiDAR sensors in the near the camera now, and so it can basically create a three-dimensional topo map of this area in front of it. And you can imagine an ultrasound goggles or something like that did a topo map of the patient's body and overlaid the ultrasound image onto that body. I mean, all the pieces are there; they just haven't been connected. And then the question is it just cool, or is it actually useful, at that point? That's a little bit harder question to answer. Going back to that needle localization technology, I remember, it's been many years, but there was a company that was producing a needle localization technique using almost like stealth technology, where they had a little box that was floating in midair, and then the needle had a separate stylet in it that was mapped to the box. And so it was a double lumen needle, and so as you advance the needle, the box knew where that stylet was in three-dimensional space. And so on your ultrasound image, it had your image, but then it had like little diagrams as overlays that would show you kind of an approximate location of your needle in all three dimensions at real time. And then it just went away. I didn't see it anymore. It was limited because the needle was thick with that larger second lumen in it, but something like that would really kind of enhance the quality of the ability of people do procedures, both in plane and out of plane. I think actually in plane sometimes ends up being harder for a lot of people because you miss that plane by a millimeter, and then you don't know where the heck you are, and you think that you see the whole needle, but you're only seeing a slice of it, and you're actually causing more damage. Sometimes I think out of plane you're more conservative, so you don't damage things, but they both have their potential value. I think that one of the things that and this is sort of a partial disclosure because it's a project that I don't have any patents on and I don't have any relationship with, but it's something that I'm working on, is I think that the big problem is that we're often doing procedures with two hands and an ultrasound with the third hand. And how do we kind of make this whole experience more ergonomic? For diagnostic POCA stuff, it doesn't matter, but for procedural things, I think that we need to figure out a way to make the whole experience of doing procedures more ergonomic with ultrasound technology. Hopefully, one of the things I'm working on turns out to be productive to that, but part of the reason I'm working on it is because I see people struggle with that every day, and especially doing things like catheter-based solutions or central access or arterial lines even, where having both hands to control the needles and catheters would be a safer way to do the procedure and more effective. So any last thoughts before we wrap up? We've been talking for 50 minutes, believe it or not. It's already gone by. Any last thoughts? This was a really interesting conversation for me. I think this technology stuff is really cool. I love tech and gadgets. I love to see what people innovate, but like many of us have mentioned, sometimes it's cool for cool's sake and we don't know how to implement it in real time. So thoughts across the pond, Johnny or Amit, any parting words? Sign up for RAUK if you haven't already. That's coming up in a couple of weeks.
Yes, please do. Please do that. Okay, Johnny.
Yeah, it's going to be a good meeting, isn't it? Apparently.
Absolutely. Absolutely.
It will be great. It will be great. I was just going to say, if you look at what Hari Shankar's written, he's great. He has all sorts of brilliant ideas, but he's written about the future is in gloves, and with the flip of a switch, a transducer will be able to deliver your local. I mean, wow. But there are local anesthetic pumps out there that operate via a foot pedal, which I think I'm being sent one next week to have a go with. I think, Amit, you may have already played with the same device. So there is a prime example. Oh, yeah. There's a prime example of, Raj, what you're saying. Both hands are still operable. Obviously, we have our operating department assistant with us who can inject, but, the problem with that possibly is you lose the tactility of pressure if you're, inside the perineum, or, you're going to do some damage somewhere. You don't know that if your foot's on a pedal on a pump to your right-hand side is the thing. So, maybe things that
you need your haptics in your foot. You need haptics in your foot.
There you go. Yeah, something that would perhaps squeeze your trainer as the pressure goes up inside the perineum. Yeah, there you go. But the technology should be there to communicate, perhaps with the devices we're using, to have another function. There you go. That's what I think.
Yeah. Steve or Nadia, any last thoughts before we part?
I think that a lot of the innovation that we see take place is almost a reflection of sort of historic science fiction imagination. And I often start my lectures kind of showing an image of the tricorder and how this, I'm a Star Trek fan, and how they had this sort of non-invasive handheld pocket-sized device that allowed you to peer inside of crew members and with vital signs pathology, and how we're getting one step closer and closer. You think about Uhura's big ear bud for communicating in the sort of old school Star Trek. I think that the more innovative technologies are probably going to come from what were considered sort of practical science fiction innovations, and so I look to sort of those types of shows and the imagination of people from generations ago looking towards the future, because I think that does inspire a lot of scientists and engineers to create the technology going forward. So I hope there's a tricorder someday. We don't even need to we don't even need to touch the patient. You literally just you scan to get the information you need.
Yeah, when Amit was talking about the AI kind of teaching you, I had this image of that movie Her with the earbud in, and as you're scanning, it's an AI version of Amit's voice telling you, no, go left, no, just do a little rotation right there, and that's all I need, is I can be just hearing him in my ear and instructing me along the way.
Well, he should be the male sat-nav voice in my eyes. I mean, he's got a beautiful golden voice, much like yourself, Raj, actually.
It's all this microphone. The microphone does all the fancy lifting.
I do want to make
go ahead. Sorry.
Yeah, no, I do want to make one comment because
Yeah,
I think that something that I encounter often is this hesitancy to change your current practice.
Yeah.
Which I think is a big factor for ultrasound and introducing new procedures, new techniques, new ways to do things. So, recently we've been doing ultrasound guided regional anesthesia with biplane views so that you can see sort of a long axis view and a short axis view of whatever structure you decide you want to see in, multi-dimension. And some of the feedback is like, oh, well, you have a great 2D image and short axis. So why do we need to do long axis? And sometimes not every patient is difficult. Sometimes you put the probe on and you have this beautiful image. And yeah, you can do it with just a two-dimensional view. But you will have the occasional patient where enhanced imaging is really helpful. And sometimes, in a trauma, you can put in a subclavian without an ultrasound, and sometimes you have to. But that's not every single patient. And there are end-stage renal patients who you cannot really do that in, and you have to pull an ultrasound on. So I just want to encourage whoever's watching, and maybe that's the wrong audience, because if they're watching, it's probably because they're ultrasound enthusiasts. But
right.
Keep an open mind to the new technologies and keep an open mind to the artificial intelligence that is being offered, because even though you may not think it's helpful at the moment, it may be the future.
Yeah, I think we have to be ready to kind of cannibalize our own expertise in the older ways to learn the new thing. Otherwise, we are quickly becoming outdated. You'd be hard pressed to say that somebody wants to carry around one of those old cell phones, those car cell phones that are like the big box, right? Just because it worked great and then it sat in your box. Nobody's going to carry those around. I actually, this story is so old because it happens, the same conversation happened with nerve stimulators when they first came around. Why do you want to waste all that time doing a nerve stimulator when you can just do a paresthesia? And then when the ultrasound came around, I remember doing a femoral nerve block when I was a first year attending with an ultrasound, and we were just getting comfortable with it. And the attending, who was the director of the acute pain service, came up to me and goes, well, that looks like a big waste of time, right in front of the patient while I was doing the ultrasound femoral nerve block, which, now granted, he's a big proponent of ultrasound now. He doesn't work at our institution anymore. But so what I find, with point of care ultrasound, now that I'm kind of old school and having to learn a new skill later in my career, what I'm struggling with point of care ultrasound is that patient interaction to say, hey, can I do this thing that I don't know if will have any value to you, but I'm going to be touching you with this ultrasound probe. And that confidence level of crossing that threshold to say, this is an important part of my care of you, even if I don't find anything, and that it's important for my future growth to care for future patients. Having that conversation enough times where my skill set gets robust is my next hurdle. I can, you guys are great educators. I've learned a lot about point of care ultrasound from all of you, but that's my next big thing to get the practice when I've got a busy clinical day to accomplish as well. So, but we have to keep learning. We have to keep trying new stuff, and maybe I'll have that little earbud with Amit talking to my ear so I can learn faster. I'm waiting for that, Amit. Just record a series of phrases. You'll be like my version of Siri, and just in my ear say, hey, Amit, what am I looking at here?
All right, just for you, Raj, I'll work on it. Okay.
Hey, look, you said that you listen to me while you sleep. This is the next best thing for me. So that's we'll leave that conversation for a different day. But
absolutely.
All right. Hey, I want to thank all of you guys. This has been so much fun for me. I enjoy listening to all of you, watching all of you, and seeing all the amazing work that you do. So it was fun to have give me a chance to talk with all of you together. Hopefully we can do it again soon.
Thanks for inviting us, Raj, and great to see all of you guys.
Yeah, thanks so much. It's been great. Thank you.
Hopefully we'll see everybody in person
Cheers,
in the
guys.
near future, hopefully. And everybody be safe out there.
Take care.
Bye, guys.
Bye-bye.